presentation today, and then it'll be on YouTube, so we can give you guys access to it. And then there's people that couldn't make it in person today, so they'll have access to it as well. We have Dr. Brian Steele here. He is a neuroradiologist. He works for Diversified Radiology, and they work with a bunch of different radiology and imaging clinics. So hopefully he's a great resource. His presentation is going to be pretty awesome today. And if you guys have any questions regarding really anything in his field, I'm sure he'll be open to fielding those. And yeah.
Well, hello everybody.
Hi.
As it says up there, and like you introduced me, I'm Brian Steele. I'm a radiologist. Dr. Anzalone asked me to come and give a talk. I put together some cases and some basic imaging from studies that I've seen of multiple sclerosis. I also grabbed some pictures off the internet where it was just a little bit easier to show things. The way I've tailored this is I'm expecting that most people don't know a whole lot about MRI and about how the imaging world works. If it seems like it's too low level for you, let me know. If it seems like it's above your head, pause, stop me, raise your hand, yell out a question or something like that. There's not going to be a lot of text on the screen. It's mostly just images. So I'm counting on people to ask me questions, to clarify things. Part of it's just going to be me talking and looking at pictures and sort of explaining how I look at it, what I look for, and how MS looks, if that all makes sense. So I've been working just as a neuroradiologist, meaning I just read MRIs of the brain and the spine and the face and head and neck, that kind of area. For the last 17 years since I finished fellowship, I've been here. I work with Diversified Radiology. We read for a bunch of hospitals in town. We read for Touchstone Imaging, and I read for a whole lot of other states for hospitals and imaging centers everywhere from Montana to South Carolina to Florida to Arizona to, I can't even count. I'm licensed in so many states I don't even keep track anymore. So feel free to ask questions, jump in anytime, and I'll go kind of slow. What I'm going to start out by doing is showing you a case. And to introduce it, let me just give you a little background. This is the slide with the most words on it. So I was reading one day, this is maybe 2 or 3 years ago, and just the next case on my queue, nothing outstanding about it. The young lady, 37-year-old, presented with dizziness and imbalance. She had headaches and she had bilateral ear pain, mostly on the left side. And the study was ordered by an ENT, or ear, nose, and throat doctor, ordered a specific study called an MRI of the IACs, that's the internal auditory canals. That's the little channels that go between your brainstem and your inner ear. He ordered that to try and figure out what was causing her dizziness and otalgia, or headaches, or ear pain. And he gave her some steroids. So I'll show you the pictures from the MRI. This is a specific kind of an MRI that's not looking at the whole brain. It's just looking at the temporal bones and the little structures that go into the temporal bones. So as you can kind of see here, we're looking at an axial picture. That's a slice through the brain this way. It goes right through the eyeballs, you can tell, obviously. This is the brainstem right here. And then these are parts of the cerebellum in the back. What we're specifically looking for in this study is to see if we can find something called an acoustic neuroma. That's a mass that grows on the 7th or the 8th cranial nerves. It's technically the 8th cranial nerve. Those are these little structures right here. You can see the arrows I put on there. That's as advanced as I get. You see these little linear structures. These are actually the nerves going from the brainstem out to the inner ear. Here's the cochlea, the vestibule, semicircular canals. These are the structures that let you hear and have balance. So this is exactly how it should look. And in this case, it's normal. So when I read the study, I said, it's a normal study, no acoustic neuroma, or the official word is called a vestibular schwannoma. And that was the end of what I did. I signed it off, I went on to the next case. Well, I found out quite a bit later that there were actually more findings on this study that I didn't see initially. And so as I kind of went back and looked at it again, now mind you, this wasn't a whole brain MRI, this was just looking at the temporal bones, but when we do that, we can see a little bit of the brain and the brain stem. And you can see right here in the right side of the pons, this little white spot. Similar little white spot over here on, by the way, to orient again, when a radiologist looks at a picture, the right is the left is the right, so I'm not that confused. We're actually imagining the slices going through the patient and we're looking up towards their head. So the right eyeball is the one on the left side of the image. So when I say This is in the left middle cerebellar peduncle. This is in the right side of the pons. Those little spots, I should have seen those initially. Yeah, go ahead.
Just a quick question. We're using contrast in this particular case.
Yes, we did.
Okay.
The contrast also, the pictures that we take after contrast was given. So some of them are before contrast, some are after.
And that's what I was just
is the point.
curious.
The images that you see here are non-contrast.
Okay.
These are T2 weighted images, and I'll talk a little bit more about imaging sequences in a short while. And I'll tell you about the contrast too. So in any case, I don't know how in the world I didn't see these the first time, and I felt my heart just sort of sank when I saw this, because this is pretty clearly going to be multiple sclerosis. Those are those little lesions that I should have seen and didn't. The only whole brain sequence that we do is a diffusion weighted sequence. This is to look to see if somebody's had a stroke. It's not good for seeing MS, but it's good enough that looking back in hindsight, I can see a lesion over here in the left frontal lobe and a couple of lesions down here next to the occipital horns of her lateral ventricles. So, you know, I've talked to this patient subsequently, and she gave me permission to use these images and to talk about this case. And it basically is just sort of, I use it as a sort of reminder that, you know, multiple sclerosis is something that doesn't always present the same in everybody. It doesn't always follow the textbook rules. And it's something, especially in a youngish woman, to keep in mind anytime I'm reading a study. Everybody could have it, but especially younger women. Although I must have been going too fast, I can't really explain what happened that day, but it's sort of terrible to think about, and it really makes me kind of choke up thinking about it, but it happens. You got to learn from it, and you got to move on. So, what I'm going to talk about next is when we are actually looking at a brain MRI, what sequences do we use to see MS? What sequences? What's the point of them? How do they work? When you get an MRI, you know, if you've ever had an MRI yourself, you know it's a loud machine. You lay in a little tube and it goes wah, 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 for like 2-3 minutes at a time, and then there's a pause and they say we're going to do something different. They tell you over the microphone, and then they take another sequence. Usually have about 7 or 8 different sequences, each one a 5 or 3, 4, 5, 6 minute acquisition, and then you get a bunch of pictures. The pictures can be displayed in lots of different ways. Typically we do it in 3 different planes. There's an axial plane, which is sort of like a slice through your body, a sagittal plane, which is a slice through this way, front to back, and a coronal plane, which is a slice side to side. Most of the pictures I'm going to be showing you are in the axial plane, like the images on the left side there, and sometimes the sagittal plane like this. The images on the left, the 2 axial pictures, are right through what's called the lateral ventricles. These are these structures right in the middle of your brain. These, the lateral ventricles and also the sulci, these spaces around the brain, are bright white on this T2 picture. The way we learned it when your first day of radiology is, they say, the mnemonic is World War II. Water is white on T2. So water, and in this case it's actually CSF, cerebrospinal fluid, fills your ventricles and it kind of bathes the outside of your brain. It cushions the brain, it allows nutrients to wash around, and it allows pollutants to kind of wash out. This is the same fluid that communicates down into your spine. When you get a lumbar puncture, you're accessing this same fluid. So you might not believe me initially, but the 2 pictures, the axial T2 picture and this axial flare picture, are both T2 weighted images, and they're essentially showing the same thing. They look quite different though, and the reason they look different is because whereas a T2 image has everything that's fluid filled is bright, on a flare sequence, it images the brain the same way, but it essentially nulls out all the fluid, the pure fluid signal. So CSF disappears and becomes this kind of black signal. The reason that's useful, if you kind of look back at the brain, you can see the cortex, the gray matter of the brain is this outer sort of etching along the surface of the brain. It's a little bit brighter than the white matter underneath. That's the same in the flare image. The gray matter's a little brighter and the white matter's a little darker. The advantage of doing a flare sequence compared to a T2 sequence is that by removing all that fluid around the brain, it's not really going anywhere, we just don't see it, it's sort of disappeared. That allows us to see the brain without the kind of distractions that the fluid can kind of create. And I'll explain why that's important in just a minute. When we do a sagittal picture, this is a single picture right through the midline of the brain, and what we're looking at is a few very key structures. This thing here, this curving structure, actually goes straight across your brain and communicates the left and the right hemispheres. It's called the corpus callosum. That's something that is very useful for your body. It's also very useful for imaging multiple sclerosis, because that's where MS plaques like to hide. We can see on the midline sagittal picture also the midbrain, which is right here. And this is the brainstem. This is the pons and the medulla. The pons is this kind of pregnant belly that sort of sticks forward, and then the medulla is this triangular shaped funnel that kind of lets the nerves communicate down here to the cervical spinal cord. So the brain communicates straight down through the foramen magnum to the cord. The midline sagittal image is useful for a lot of other reasons too. I won't get into it, but these are sort of like the key anatomic things that we look at. When I'm looking at a brain, the first thing I do pretty much when I look at a brain MRI is try to decide. I try to not look at the history right away, and I try to guess how old is this patient. The way I do that is I kind of compare the amount of brain tissue to the amount of fluid inside and surrounding the brain. The skull is a very fixed volume, right? So the brain should basically fill it up with fluid kind of filling all the spots that the brain doesn't fill. If the brain shrinks, if it loses volume because of atrophy, which can happen as you get older or because you have some kind of a disease, it's not like the skull is going to change. So what has to happen is you have to have more fluid kind of filling in the spaces that the brain is no longer occupying. So this is kind of how we determine whether a brain is atrophic or atrophied, is by looking at the difference between the amount of brain tissue versus the amount of fluid inside the skull. When you've read 8 million of these things like I have, it comes pretty quickly. Like you kind of glance at it and say, oh, this patient should be about 45, 50 years old, you would guess. If they turned out they were 20 years old, I'd be worried. I'd say something's wrong. They've more atrophy in their brain than they should. If they're 80 years old, I'd say they've done a great job. Whatever they did, they did it right. So let's take a look at these next pictures. This is the same patient, another axial T2 and axial flare sequence. This is an MS patient. And if you look very closely, you can see there's one known and unchanged MS plaque, this little dot right here. You can maybe appreciate that it's a little easier to see on the flare picture compared to the T2. But basically the rest of this brain looks pretty normal on this slice. They came back in a year and 2 months, 14 months later, and if you ignore that sagittal picture for the initial thing, we have matching axial T2s a year apart, and we have matching flares a year apart. So if you're just looking at the T2 sequences, you'd be hard pressed to sort of see what exactly is the difference here. But on the flares, it kind of jumps out at you pretty obviously. This is that lesion that I mentioned a second ago that's unchanged. It's been there a long time. It's not any different. But what you can see pretty clearly is that there's this new little blotch. This is in the subcortical white matter for parietal lobe. And if you look closely, you can actually see it here on the T2 picture as well, right? But when the CSF is filling in all these invaginations where all the sulci kind of fold into the brain, it really can make it hard to see. So that's sort of the advantage and why we use FLAIR more than any other sequence to sort of see white matter lesions in the brain. Both these lesions detect things that are fluid filled and things that are either edematous or gliotic or inflamed. Things that draw more water into the cells show up as bright spots, just like the water is bright. FLAIR doesn't make those spots disappear though, it only makes the free fluid in the CSF disappear. Yeah?
And to me, that little white spot, the
Down
higher
here?
white spot, no, the other one,
Uh-huh.
is bigger in that picture
Mm-hmm.
than the one above it. So is that doesn't signify that it's gotten worse?
That's a good observation. I would say it doesn't really look to me bigger, but it's sort of brighter and more conspicuous. So every time we take an image through the brain, that slice has a particular thickness. Usually it's about a 5 millimeter slice. It's a 5 millimeter selection of brain tissue, obviously compressed into 2 dimensions, right? So it's very flat. And then usually we skip 1 or 2 millimeters before the next slice is acquired. So if a particular slice goes right through a lesion, like I think it's going exactly through the center of this lesion here, it'll grab more of the signal from that lesion, whereas this one may have kind of glanced through it. So it might have just caught the top of the lesion, enough to show it on the image, but not showing it quite as brightly as it did here. It's one of those things you kind of get used to seeing over time, and it's a very valid observation. It does absolutely look brighter here, and it catches your eye quite a bit more easily. And sometimes that can be tricky because if a lesion happens to be right between two slices, you may miss it completely. Or it might show up on one study, and then on the next study, it's a lot less conspicuous. So image slices make a difference, and slice position make a difference as well. That's totally true. And you can see here on this sagittal flare sequence, this is just off midline. This is probably a slice going right through the brain, like right in this plane. So it's cutting right through the lesion, and that's why it shows up right here. If we were one slice to the side, it might just show kind of a fainter little blush of brightness. Yeah.
Does the corpus callosum correlate to the lateral ventricles at all, as far as like seeing them on both slides there, or?
You can see the corpus callosum if you, let's see how I can kind of describe it. So the two ventricles kind of go like this, right? They kind of parallel each other like this, and if you look at them in the coronal plane, they're sort of like little horns that I can't make my hand stick out there, but they're kind of like this. The corpus callosum is right above it, and it's sort of like a broad ridge that goes right above the lateral ventricles like this. So it's usually just above the lateral ventricles, and then between the lateral ventricles there's a very thin kind of dural flap called the septum pellucidum, which separates the two ventricles in most people. I hope that answered your question.
Yeah.
So the corpus callosum communicates between the left and right cerebral hemispheres right above the lateral ventricles. Now if we look at this, this is the same image, the left two images are the same pictures that we were just looking at on the last slide. There's that little new MS plaque. And when I read an MS follow-up study, I'm looking to see if all the lesions that were there before are still there. Have they changed, or are there new lesions? Whenever we see a new lesion, especially, I guess with all lesions, but mostly when we see new lesions, we also want to see, is it an active demyelinating plaque? The active demyelinating plaques are typically the ones that cause the symptoms. They're typically the ones that cause new symptoms that sort of, when you have a flare-up, is when you have sort of a new acute lesion. And while T1 imaging, there's sort of two big parts of MRI, T2 imaging and T1 imaging. T1 imaging is not as good for seeing the lesions themselves. This is the same picture, and you can see this is the lesion right there. But you would never want to depend on this image to find that lesion. It looks just like the gray matter next to it. It's indistinguishable, not conspicuous at all. But the use in it is that once we give contrast, we can see that in this case, this new lesion that wasn't there a year ago is also showing enhancement. Enhancement just means the blood is flowing to that lesion, and it's, we give contrast into the vein, as you know, and the contrast goes wherever the blood goes. So things that are acutely inflamed or active, like an MS plaque, will deliver more of the contrast to that spot, and that's why they show up as sort of bright enhancing things. So these two sequences are basically the same. This is before contrast was added, and this is after, so we know it's an enhancing active plaque. When you see something that's enhancing like that, that's usually, for me, when I call up the doctor and say, listen, first of all, it could be on somebody's presenting MRI, in which case, that sort of explains why they're having the symptoms they're having. Go see a neurologist. If they're a known MS patient and you see an enhancing lesion, that's when I typically give a call to the provider and I say, whatever you're doing, it's not working. It's time to try something else, or up the dose, or whatever needs to happen. I don't really know how that works exactly, but I know what I see is something changed in a bad way, even though they were getting the treatment they're getting.
So if you get contrast, you can basically, for contrast, it's just to see if it's active.
In this setting, yes, that's basically what it is. You're looking to see if any of the plaques are active. Exactly, if they're actively demyelinating. The chronic ones is kind of like this little lesion over here. If I had looked back over a couple of studies before that, it was no different. Every study looked exactly the same. It didn't show an enhancement, and you can see here. I don't know if we go exactly through it, but it doesn't enhance, right? It doesn't look like this one for sure. That's sort of like, you can imagine it You can imagine like if you cut your arm, right? Initially it hurts, and then it gets red and kind of inflamed, and it gets warm. That's the blood rushing to it, that's the inflammation rushing to it. Over time, as it becomes a chronic thing, it becomes like more like a scar, where it sort of gets smaller, it gets less conspicuous, and sometimes you can still see it there for years and years afterwards, right? It's just sort of like a little injury that's sort of permanently there. That's kind of how you can imagine these chronic MS plaques. Once they're there, that part of the brain is sort of damaged. It's sort of irreparable. It's not going to sort of get back to normal. The enhancement that's initially there, just like the redness and the inflammation around the cut on my arm disappears, the acute inflammation also disappears, so the enhancement will go away over time. It's a little different for every lesion in every patient, but the inflammation will typically go away over a few weeks. If we brought them back 3 weeks later, most of the time it'll be gone or a lot less. But we use contrast for MS. We also use it for lots of other things too. Tumors enhance, blood vessels have blood in them, so they enhance as well. So contrast basically follows blood, and blood follows inflammation and other things.
So in this MRI, what new symptoms might you expect to see in a patient with a plaque in that location?
That's a great question, and it's not an easy one to answer, if I'm being honest. So, the part of the symptoms that someone might have from an active plaque in a part of the brain will depend on what that part of the brain does, right? So that's sort of logical, it makes sense. The brain isn't quite so easily compartmentalized, right? So this part of that the right cerebral hemisphere generally controls the left side. It controls your movement on your left side, so your motion and your senses on the left side, because the nerve fibers cross in the bottom of the brainstem. So we know very specifically some anatomic locations that will cause specific symptoms. If you have an MS plaque or a stroke in what's called your prefrontal cortex, or your precentral gyrus rather, that's the motor strip. That's going to affect a part of your body on the opposite side that we can strictly define. There's something called the hand knob, which is a specific little bump. If there's a lesion there, you're going to have a symptom in your other hand for sure. Like in the first patient I showed, she had little lesions in her posterior fossa, in her cerebellum and in her brainstem. Typically, patients with those kind of lesions will present with dizziness or vertigo or some kind of positional kind of problems. The problem is the brain has a lot of interconnectivity. So especially in a place like the brainstem, where there are many, many nerves coming, tangling, communicating with each other, the symptoms that you get can be very hard to predict. They can be, you can have a general idea, you can have a general idea what it might do, but because the interconnectivity of all those different neurons, you can be sort of surprised too. So in this case, in the posterior paramedial right parietal lobe, usually the parietal lobe is more for sensation. This is close to the occipital lobe where the vision is, but I wouldn't really expect this to affect vision. I would expect this would, if it was going to cause symptoms, it could cause numbness or something like that, probably in the left side of the body. But I would hate to be, pinned down and say, what's this lesion going to do? Because I can't really tell. And I'd be lying, and I think most people would be exaggerating if they thought they could predict exactly what a given lesion would do. So, and the other thing is, a lot of lesions are silent. There are lots of parts of the brain where there's enough interconnectivity that an injury to that little part of the brain can be overcome. Just the neural connectivity can allow the brain to sort of adapt to it and not even show any symptoms. Or it's just sort of some kind of clinically silent little white matter connection that doesn't manifest in a patient. So we can see enhancing MS plaques in a patient who's asymptomatic. It doesn't always work as cleanly as you would hope. So I'm gonna kind of go through and show you when I look at an MS patient's brain, what kind of lesions I'm mostly looking for. And to start out, I'll show you these. These are two different patients. The top row is the first patient, the bottom row is the second patient. Both of these are FLAIR images, right? So the CSF in the ventricles is gone. And you can see on this top patient, little blotchy white matter spots here and here, both sides of the brain, kind of all over the place. Maybe a little one right here in the right thalamus, here next to the atrium of the lateral ventricle. So several little dots. Well, this one doesn't look a whole lot different. There's some patchy signal right over here next to this ventricle, some next to this ventricle, over here in the subcortical white matter, next to the atrium here. The thing is, and maybe over here in the corpus callosum, not everything that causes a little spot in the brain is because it's multiple sclerosis. Lots of other things. I bet if we took an MRI of everybody's brain in here, everybody would have at least one dot in their brain, even if you were perfectly healthy and nothing had ever happened to you. As we get older, nobody knows exactly why it happens, but they call it chronic microvascular disease. So if you see on your report small vessel disease or chronic microvascular disease, those are the words that we use to explain a phenomenon that nobody really understands. It's that as we get older, the brain doesn't look quite as clean on MRI. There are little dots that start showing up. The hypothesis is that it's probably due to tiny little blood vessels that sort of don't quite make it. And although they're supplying that part of the brain most of your life, at some point they kind of shrivel up, don't quite make it, the blood doesn't get there, and that little part of the brain dies. So in your mind, you can imagine it as a little micro stroke. That sounds scarier than it is because every single person that you pull off the street will have these kind of dots in their brain. Other things that can cause similar kind of white matter spots are migraine headaches. They're classic. If you have a head injury, that can also cause things like this. There are probably myriad other causes as well. All kinds of vascular phenomena can cause white matter spots. So when we see white matter spots in the brain, we can't call everything MS, and we don't. We look for specific patterns. So in this case, the top patient was somebody with headaches. She's 59. She maybe has a little bit more white matter disease than I'd expect a 59-year-old to have, but this would be very typical if she were a smoker, say, or she was a diabetic. Those patients tend to have accelerated development of white matter disease. The bottom patient, similar age man who had MS, and I would have been able to say that this is more likely to be MS, and some of the lesions are kind of characteristic of MS, but not of those other processes. You don't get white matter disease nearly as frequently in the corpus callosum, and this is the right side of the splenium of the corpus callosum. This kind of blotchy signal next to the ventricle, especially if we saw it in another plane, would not look the same as the little white matter lesion here, even though they look very similar in the axial images. So a lot of that comes with looking at a lot of these pictures and sort of learning the patterns, but you can kind of also look for specific patterns of white matter disease. So you may have heard of something called Dawson's fingers. This is a I grabbed this off the internet because it's just a good picture. These, you can imagine a hand going like this, right? And these are the fingers. The white matter lesions in MS tend to spread radially away from the lateral ventricles up along something called the perivenular spaces. These are tiny little spaces that are usually invisible on a brain MRI or even to an anatomist, but the demyelinating disease, for whatever reason, tends to grow in that pattern away from the lateral ventricles. So when you see streak-like or flame-like little lesions that extend away, sort of in a peripheral pattern away from the ventricles, this is a ton of them. You don't usually see this many, but this is MS. There's no way about, this is not microvascular disease, this is not migraines or anything like that. When you see that, you can be pretty sure. When I go through these lesions, I'm going to show you one. I came across a patient last week, I think, this 50-something-year-old guy who had a lot of lesions like this. So I'm just going to sort of show you his lesions are very characteristic kind of lesions in MS. And this is his MRI that I read last week. Not as robust as the last one, but you see how these lesions are kind of ovoid. They kind of extend away from the lateral ventricle on this sagittal picture. Now in the axial plane, when we're cutting as a slice right through them, they look like little round dots. But when you look in the sagittal plane, they have an orientation to them. They look different than a microvascular lesion would look. So Dawson's fingers and the periventricular white matter are very classic. Like I was saying earlier, lesions in the corpus callosum are not something that you get with microvascular disease, small vessel disease, but very common with MS. This bottom edge of the corpus callosum is called the septocallosal interface. It's between the callosum and the septum pellucidum that I mentioned earlier. That bottom edge, if you start getting a regular bright signal along there, that's not something that's pretty telltale of MS. Or you can get more robust lesions invading the substance of the corpus callosum. Corpus callosum lesions are very characteristic of MS and not very characteristic of other lesions. You know, when I say these, there are almost no absolute rules also. There are exceptions to every rule that you can think of. So there are plenty of times I have to say, this is, you know, unlikely to be MS, but I'm not gonna say it's not MS, because you can have a little innocent looking white matter dot right in somebody's subcortical white matter that 99 times out of 100 is just somebody had a migraine years ago, or they're 45 years old and they have a few dots in their brain. Could it be MS though? Absolutely. I've seen exactly that scenario where something that looks completely innocent ends up being MS, and vice versa. Sometimes we think things look like MS and they're not. So nothing is absolute, but these are sort of the general rules that we follow. Yes?
So what do you do, just take more MRIs to make the decision, or you have to look at the actual symptoms?
Absolutely. That's the second thing you said is the key. MRI is a tool, right? It's helpful in deciding whether something is a specific disease or not, but we're not treating MRIs, right? We're treating patients, and if a patient doesn't have symptoms and they have a few sort of suspicious dots, do you really want to start giving them medications if they're absolutely responding to medication? I don't care what their MRI looks like, right? So it's a tool that aids the neurologist in trying to figure out what it could be, but it's not the be-all and end-all of making a diagnosis. You have to sometimes lumbar puncture can be helpful, right? Because they can evaluate the CSF under a microscope, see what kind of proteins are inside the CSF. That can aid in the diagnosis. Certainly a patient's symptoms and presentation, they say, you know, I was real numb in this leg, you know, a few months ago, and now I got this weird little paresthesia over here in my other arm. That sounds like MS, and even if I saw a brain MRI that was normal, it wouldn't mean it's not MS. So an MRI is helpful, but it's not the total evaluation of the case. In any case, this is that same patient that I saw last week. This is the splenium of his corpus callosum. It kind of spreads out in the back of the lateral ventricles like this. This is an MS plaque until proven otherwise. That's what they look like. This is a spot where they usually like to hide, and it's a very characteristic lesion, which you can also see in the sagittal pictures. Yeah.
So, sorry, I'm not too well with these terms, but
No.
The CSF, like the one that you see there, does it run from like the top all the way to the bottom? Because
The CSF, meaning
like the middle part, yeah.
this
Right,
corpus callosum thing, or?
Oh, on the other one? Yeah, that one.
Yeah.
Because in my last MRI, I saw a very big lesion, like on that or somewhere around there, in which is cognitive issues. But I'm just wondering, does the CSF?
I'm not sure I'm understanding the question exactly.
Does the CSF,
Mhm.
if you see it in an MRI, would it show like that brightness of white all throughout, like from top to bottom? Or will there be brain in between the middle?
You will always, for the most part, the CSF is around the outside of the brain tissue, like kind of bathing between the brain and the skull, all circumferentially, all the way around, front, back, top, bottom, left, right. And it's also in the center of the brain, in the ventricular system, these lateral ventricles. All of that does communicate with each other, but not sort of, let's see if I can do it. It all does communicate, right? So if even the CSF down in your lumbar spine communicates with the CSF around in your brain. It's a circulation system. The CSF is produced by something called arachnoid granule. It's produced in the choroid plexus, actually, which is actually this is the choroid plexus. It's hard to really see, but it's this kind of stuff within the ventricles that makes the fluid. It circulates from the lateral ventricles through the third ventricle, through the fourth ventricle, and down into the spinal cord, into the spine. And then it circulates all the way around again And these little sort of like drains that are at the top of your brain and in the back of your brain, called arachnoid granulations, they resorb the CSF. And that balance of your body finely tunes this sort of production and resorption of CSF so that you always have the same amount. It follows a complex kind of pattern around your whole brain and spine, but the brain itself is kind of bathed by CSF, but doesn't have CSF in itself, if that makes sense, if that answers your question. I could talk to you about it more later, I guess. I'm not sure if I'm answering your
I was
question
just
right.
trying to understand my MRI, and when I talked to Dr. Anslow, and I saw the picture, you know, I should have seen my picture before I came, but, you know, it just looks so huge compared to the other lesions that I have that look so tiny.
Well, I think if you're seeing an MS lesion, that's not actually CSF. CSF is the fluid around your brain. An MS lesion it's brain tissue that just has been infiltrated by inflammation. And the inflammation includes some fluid. That's why there's brightness to it on a T2 weighted picture. And so sometimes an acute or a new or an active MS plaque will be bigger than the other plaques that have been there a long time. It's kind of like the same way, like I said, if you cut, sometimes you get this acute inflammation, it kind of swells up, or a bruise, it gets big initially and then it kind of quiets down over time. The new MS plaques tend to be bigger. Over time, once they age and once they might be treated effectively, they'll sort of shrink down, and so that they're not actually causing any mass effect in the brain. They're the same size as the brain was initially. They just have it's like a little scar. But the new ones are definitely usually bigger. They look kind of angrier. They can enhance, and they can sometimes even cause a little bulky mass effect. They can kind of push on things nearby. So anyway, so the splenium of the corpus callosum. This is the splenium of the corpus callosum. The whole corpus callosum is a place where MS plaques like to be. This is the brainstem. This is a T2 weighted picture in the axial plane through the pons. All these little dots. This is something I grabbed off the internet just because it was a dramatic case. But lots and lots of little spots touching one another. I can't count them. It becomes hard in somebody who has advanced MS because there are so many lesions. You can't count them. You can't say, oh, this one's here was last time, here's this one. You'd be there all day and you'd never be able to even decide what was what. They kind of overlap each other, they're confluent, so it can be very confusing. But when you see lesions in the brainstem like this is very suspicious for MS. And our gentleman who I saw last week, he had more, not quite as robust a load of lesions in his brainstem, but certainly this is an MS plaque in the left ventral pons. Here's one in the back right side of the pons. Here's one kind of right in the middle of the pons. This lesion is the same as this lesion. We're just seeing it at a different plane. So MS lesions like the brainstem. Another very classic place, including in the case that I started with, is right here. This is called the middle cerebellar peduncle. It's kind of like you can imagine the cerebellum being a piece of broccoli, and this is the stump of the trunk of the broccoli. Or the Latin word for this structure is a brachium pontus. Brachium is your arm, pontus is the pons. So this is sort of like the arm coming off of the pons. You have one on each side, and these are very classic places for MS plaques and not much else. This lesion happens to show enhancement on post-contrast imaging, meaning it's an active lesion in the brachium pontus. The cerebellum is much in charge of balance and things like that, so the nerves that exit the cerebellum and come to the brain might be interfered with by this lesion. So you would expect somebody with a lesion here to probably have imbalance or vertigo or some kind of vestibular disturbance. Our guy didn't really have any MS plaques, but these little dots in the cerebellar white matter themselves are also pretty characteristic of MS. So when you see them in the back in the white matter of the brain, white matter of the cerebellum, these are also characteristic of MS. MS lesions are almost always in the white matter. They can be in the gray matter, but it's much less common. It's called a demyelinating disease, and myelin is a kind of a coating of nerves that is much, much more prevalent in the white matter compared to the gray matter. So when something is affecting the myelin sheath, it's affecting the white matter of the brain or spinal cord predominantly. much less likely to happen in the gray matter. You can see gray matter lesions. I do see them frequently, but not that common, not nearly as much as a white matter lesion. And here's the gentleman from the other week. He has these little lesions in his right cerebellum. Sometimes they can be kind of hard to see. They kind of fade away as you scroll up and down, but those are definite MS plaques for sure. Yeah.
So would those also be lesions kind of just in front of the brainstem there, where we kind of see that?
Right up here?
Yes.
This guy, absolutely. So this is another part, this is part of the pons. Here are the brachium pontus, the arms of the pons. And this is a little bit lower down, but we're close to the medulla, but it's still in the pons, I think. And these are probably that lesion, this lesion, this lesion. These are probably all lesions. It can be confusing. Sometimes you get artifact. An artifact can be from a different thing. Sometimes the patient will move a little bit on the scanner. That causes these sort of shadows and echoes that can be confusing. They can kind of mix you up. You can see here this patient's eyes are moving, and so it looks kind of blurrier, not as crisp. Sometimes what you get through the brainstem especially, you have blood vessels right over here and over here called the jugular veins, and sometimes the pulsation of blood through those veins causes an artifact that shoots across the brainstem like this. It's purely a technical thing. There's nothing actually happening there, but the pictures are distorted by that pulsation movement, and that can cause bright spots that aren't MS plaques. So in this particular case, I don't remember the exact image, but I'm almost certainly these are MS plaques. But this is a spot where I would be cautious if that was the only thing I saw, because I'd have to make sure there was no artifact going across the brainstem too. But you're right, these do look like MS plaques. He had a pretty severe burden of disease. Yeah.
How can a pill or an injection change that?
How would an injection change that?
Yeah.
When we inject contrast, what we're basically doing is trying to look at those individual plaques and seeing if they are active. They won't cause more artifact, though, if that's your question.
This, what is it called?
DMT.
Yeah, he's talking about medication.
Oh, the medication.
Yeah.
Medication, if you were going to get a medication to treat your MS, you're mostly trying to prevent new MS plaques from forming, and you're trying to treat the active MS plaques that might be acutely inflamed or causing symptoms. The old MS plaques that are the little dots that have been there for years and years,
They won't go away.
they don't go away, and I don't think they're also not causing symptoms actively usually. It's sort of like a scar on your skin or a tattoo or something. It hurts initially. Once it's there, it's just kind of there. Your brain will adapt around an old lesion. It isn't really treated by the medication anymore because it's not actively causing symptoms. It's not actively demyelinating. The damage is done in some way. Does that make sense, or does that answer your question?
Kind of.
I'll take that. Well, feel free to press me if it seems like I'm being evasive. I don't mean to be sneaky or something. Sometimes I don't know the answer, but I think the answer to what you're asking is medication is used to treat active lesions and to prevent the development of new lesions, not so much to treat or make old lesions go away. So an old lesion is sort of there and not causing symptoms, never going to go away on the MRI no matter what you do, and kind of in the past. So they always talk about MS lesions being dispersed in time and space. So when you see new lesions coming up and old lesions getting smaller, they show up on the left side of the brain, then they show up on the right side of the brain. That's what they're talking about, this dispersal in space and time. And what you're trying to do is to sort of interrupt that appearance and changing nature of the disease. The lesions that have been there for a long time are always kind of going to be there. You're trying to make sure nothing new shows up, and that active lesions are quieted down.
But if you had no new lesions over a period of years,
Yeah.
does that mean you don't have MS anymore?
It does not mean you don't. No, that's not correct. If this might be a better question for the neurologist than for me, but my understanding of it is we have stable disease, meaning it's not changing, it's under control, but it doesn't mean it's not there. So if you have MS I see patients all the time that have no change from last year, no change from the year before, no change from the year before, they still have MS. They have sort of dormant MS, or it's well controlled, I think is the way to describe it. It's not gone.
But can it come back?
Mm-hmm.
It can.
Yeah, it can. And there are different types of MS, and some are more aggressive to come back. Some can sleep for a long time and then come back. It's in some ways it's kind of like some cancers. Some cancers are quiet, they've been cured, but they can come back years later. And MS is sort of the same way.
I might need, I have another question, sorry, about
Yeah.
On different views, if you do cervical or thoracic, you're only looking for demyelinization at that level. You're not seeing lesions, correct? Lesions are, only in.
Well, lesion is, when we use the word lesion, it's because we don't know what we're talking about. A lesion is just a little thing that we notice that isn't normal, and we're not sure what it means. It could be just an innocent little spot that everybody gets when they get older, or is it an MS plaque, or is it a tumor, or something like that. So a lesion is a grab bag word for when we don't know what something is. MS, when we say a demyelinating lesion, that means we know it's an MS plaque. I'll show you some pictures of, actually just in a minute, I think maybe the next slide. We'll look at the spinal cord, and maybe that'll show you what lesions look like in the spinal cord.
But
So
you couldn't diagnose just off the spinal cord. You'd have to have a brain.
you can absolutely get MS just from the spinal cord.
Okay.
I saw a patient today, in fact, that had a single MS lesion in her, or I don't remember if it was him or her, but in their cervical spinal cord, they had one single lesion. Didn't see anything in the thoracic spine, didn't see anything in the brain. I guess I don't know for sure that it's MS, and those are the cases that there's some ambiguity, and those are the cases where it really matters their clinical history, their neurologic examination, their CSF analysis. When I see a lesion where this patient's lesion was in the cervical spinal cord, it should be MS, but one lesion is not enough to make the diagnosis. So I can say this should be MS, but I can't make that as a diagnosis. Those are the ones where we end up saying consistent with MS, but not sufficient to make the diagnosis, or looks like MS, but we need to get follow-up. We need to get more imaging. There's not always an answer. Here's sort of a case kind of like what we're just talking about. This patient, I don't remember how they presented, but it was in September of 2024, and this is the cervical spine. Again, you can see the brainstem here coming down to the medulla into the cervical spinal cord. There's the cerebellum. The CSF kind of flows down from the fourth ventricle, circulates through the spine. You can actually do studies that sort of show the movement of the CSF, so it does sort of flow. It goes along. The flow is controlled by the pumping of your heart. Actually, it's pretty cool. I forgot what I was saying. But anyway, so it does all kind of communicate. Here's my proof that the CSF does communicate between the brain and the spinal cord. So it does it's all the same fluid. In this patient's spinal cord, you see this little bright spot. We count vertebral bodies. This is C2. There is no, C1 is kind of fused with C2 and everybody. So this is C2, C3, C4. This is the C5 body. This is the C6 body. And these darker things are the discs in between the vertebral bodies. So this lesion that we see in the spinal cord, lesion because I don't know what it is, but it's not supposed to be there. This is a lesion in the cervical spinal cord at the C5, C6 level. When we took an axial T2 picture through the exact same level, this is a cut going right through this disc. We can see the lesion is on the right side of the spinal cord. Again, right is left, left is right. MS lesions are rarely right in the middle of the spinal cord. They're usually off toward the side, usually kind of a little bit toward the back or a little bit toward the front also. They're kind of eccentrically located. But there's a solitary lesion in the right side of the spinal cord at C5, C6. This is the post-contrast picture, and we see it enhancing over there. In this case, we would expect some kind of right-sided symptoms. This lesions on the right, and it's right-sided symptoms. That's because nerves right around here in the bottom of the brainstem crisscross. So left and right become natural, and that's why the nerves exiting your spinal cord on the right control your right leg, for instance, even though your right leg is controlled on the left side of your brain. The nerve coming down crisscrosses over right at the bottom of your brain. So this will probably cause some right-sided symptoms. So if we look at that same patient, here they are in September of 2024, and there's a lesion right at the C5, C6 level. They came back 6 months later, and you can, maybe you have to believe me, but you can kind of see that there is still a little bit of funny signal there, much less extensive than it was the first time though, right? This is because the lesion that initially was enhancing and active is now quieted down. It's either just become older or it's been treated and effectively treated so that it has not gone away completely, but has sort of become a lot less conspicuous, and if it, as big as it was, now it's smaller. But if you're carefully looking, you might notice that right above it, there's a little new spot that wasn't there back in September. So what we're doing is one lesion quiets down and another one pops up. Then if we look at that C4, C5 lesion, because it's between the C4 and C5 vertebral bodies, it's also on the right side, and on post-contrast imaging, this is a contrast-enhanced sagittal picture. Here's a contrast-enhanced axial picture. The lesion's on the right side of the cord. This is a new active demyelinating lesion at C4, C5. So one got better, one came up and was new. And that's sort of the nature of the beast with MS. They sort of, lesions come and they go, and you try to control them, but it's in some ways kind of like a whack-a-mole situation. You can't always control them all. Yeah.
Are C4 through 6 kind of like pinching into the...
A little bit, yeah. So,
cord there?
yeah, this is, this is not MS, obviously. This is this is degenerative disease.
Yeah.
So your discs are these kind of cushiony little things between vertebral bodies. As you get older, they lose some of the fluid in them. They become a little harder, a little less cushiony. And they can also, instead of being contained very well with this annulus, with this fibrous band around the outside, the band can break and you can get what's called a disc herniation. So this is a bulging or a herniated disc. It's hard to tell here, but there's probably little bony protuberance there, osteophytes. If these get big enough, they can smush the spinal cord. They can also cause signal abnormality in the cord too, which can be confusing because sometimes the signal abnormality caused by a disc herniation or by degenerative disease can be very similar to what an MS lesion looks like in the brain. So that would not cause enhancement, though. The enhancement is something that's only done by something that's like a demyelinating lesion or a tumor, I suppose, but in this case, an MS plaque. Yeah.
I have 2 questions.
Okay.
Is the spinal cord the same as the brain, that you don't know like what it usually affects? Like in C4, it can be anything, or it could be like C4 affects the legs, or C5.
That's a good question. So as your spinal cord goes down from here all the way down to the back of your lumbar spine, at every single level, it gives off a nerve to the left and to the right, 2 nerves, one to the left, one to the right. That happens at C2, C3. Your C3 nerve exits there. Then the next level down, the C4 nerves exit. Each of those nerves goes to a different part of your body. So it's easier to think about maybe in the lumbar spine, but the S1 nerve goes sort of to your butt and the back of your upper thigh. So if you have a disc herniation that hits the S1 nerve, that's when people say they get the shooting pain right down there. If that disc herniation was actually not at L5S1, but it was at L4, L5, it'll hit the L4 nerve root. Then it'll affect a different area of your leg. These are called dermatomes. So the area of the body that the nerve supplies is called its dermatome. And depending on where an MS lesion is in the spinal cord, you can do a pretty good job of guessing what nerves might be affected. At least you can say if it's below a certain level, it won't affect anything from above it, if that makes sense, right? So if you have a lesion down in your lower thoracic spinal cord, that's not going to affect your arms, right? Because your arms, the nerves supplying your arms have already exited way above that. So you can kind of narrow it down. It can be tricky though, because a lesion in your cervical spinal cord, all the nerves going to your legs are in the cervical spine too, right? So the higher you are, the more commonality there is. There's more shared space, sort of. It's a common big highway for the nerves to go down. Whereas in the bottom of your spine, it's just the things going to the, you know, your pelvis and your legs and things like that. So, and right goes to the right, left goes to the left when you're down in that part of the spine. So you can kind of get closer to an answer, but I would say if you showed me what is this lesion affecting, I don't want to predict. But at C4, C5, the C5 nerve and the C4 nerve go into your brachial plexus, so they definitely go to your arm. I would expect some kind of right arm symptoms.
Okay. And my other question, so I've seen my MRIs and sometimes there's nothing new or nothing active, but I do have, I guess, what it's called, the sumo, I don't know. Do you guys know? Sumo. Pseudo relapse?
Yeah, that's
Or
like a
pseudo relapse?
Pseudo relapse?
Pseudo what?
Oh, you've had a pseudo relapse?
Like,
Oh, pseudo relapse.
that you feel, that you like your arms go numb, but there was nothing new in the lesion. So, like you said, old lesions are like kind of like not active, but is it just like the memory and the nerves remembering like what happened?
That's a good question, and I don't know the answer if I'm being honest. MS lesions are varying in size. If they are small enough, if there's an area of demyelination that is small enough, it might not even show up on our MRI, or it might be between slices. So we don't get a perfect picture of the brain enough to sort of see every cell, right?
Everything.
So if there's a small lesion that is in between slices or just too small for the detection limits of our machine, that could explain it. Maybe, and I'm kind of guessing a little bit here, but perhaps an older lesion, if the milieu around it, if an old lesion is being pushed in a different way or is slightly, sometimes, for instance, it's easy to say in the cervical spine, sometimes if people have symptoms when they tilt their head this way or that, it's because only when they tilt their head in a certain position, a certain part of the spinal cord gets bumped into or squished in a little bit different way. So I can imagine that something similar might happen in the brain as well. Maybe not from something pushing on it so much, but the tissue next to it being inflamed or something like that, so that you can kind of get a carryover effect. So maybe sometimes the symptoms that you see aren't from a new MS plaque, but from a slight distortion in the tissue around it.
Okay.
I'm guessing a little bit, and I don't know the answer. Is the short story.
One other thing that they were pointing out too is also some types of like colds or infections can also kind of bring back some symptoms during that period. So that could also be a reason. That's why like Christina might go like, hey, maybe we should like check it, like let's look into this. Or have you been sick at all? Have you had any infection?
Or stress.
Stress
Yeah.
too. That's
Heat.
another one.
Yeah, because I definitely see when I get stressed, I have this thing that I already know, my arms start vibrating,
It's absolutely true. I think I get this. I think that kind of when you're really tired or dehydrated or something, your sort of ability to. So maybe most of the time when you're walking around feeling good, healthy, the very minor signals that the MS plaques are sending, your body can overcome them. They can kind of ignore them. But when you're a little bit weaker, when you're a little tired, when you're a little dehydrated or whatever it is, maybe then your body isn't able to sort of overcome the signal, the nerve symptoms that the MS plaque has always been sending out, but usually you just don't notice because your body is strong enough to overcome them. So I think that there's always sort of like a more systemic answer than just what's happening in that specific spot.
Thank you.
Sure.
Can that also be misdiagnosed? Like, I have a lot of problems there, but they said spinal stenosis.
Mm-hmm.
Is that not? Could it also be MS?
Yes. Well, it can be very tricky. So the other day, for instance, I saw, I don't remember the age or gender of the patient, but somebody had a cervical spine problem, and they had some degenerative changes for sure. They had some osteophytes and a disc herniation, and there wasn't a lot of room for their spinal cord. It was it was something kind of like this, and it was bumping into the spinal cord just a little itty bit, just not squishing it completely, but just bumping into it. And then in the spinal cord next to it, there was some bright signal. You can get bright signal from edema, from a disc herniation that is mechanically pushing on the cord, for sure. But it looked to me like there was more signal in the spinal cord than I could attribute to that little disc herniation. It didn't match up exactly. And so in those situations, it can be tricky, and sometimes we say, this signal, maybe it's just because the disc herniation is bumping into the spinal cord, but we can't say for sure. Maybe there's an MS plaque there too, or maybe the disc herniation just happens to be at the same spot as the MS plaque. So different problems can cause the same abnormal look in the spinal cord, if that makes sense. And they can both be there too.
I had like C4 to C6, I had ACDF.
Mm-hmm.
Would they see that?
Yes,
If they open it? I mean,
well, whenever I read a spine MRI or a spine CT, I can for sure see the hardware. I see the hardware there,
yeah.
and I can see the spinal cord behind it, and I can see whether usually you can tell whether there is an injury in the spinal cord. A lot of times people have those ACDFs because in the past there was injury to the spinal cord. So behind where the hardware is, sometimes there's a little injury in the cord.
mm-hmm.
And we usually presume that injury in the cord is because of the mechanical problem, the disc or the bone, rather than a demyelinating lesion. It's sort of Occam's razor, right? So we kind of assume it's all one problem rather than multiple problems.
Yeah.
So can we be fooled, or can they both exist at the same time? Yes.
Okay.
It can be hard sometimes.
But for MS, they only do an MRI for the brain.
No, they do.
They do the spine as well.
Yes, the cervical, there are 3 parts of the spine. So the cervical spine goes from here to the top of the ribs, C1 through C7.
Yeah.
Then there are 12 thoracic vertebral bodies, the ones that have
Right.
ribs. The spinal cord usually ends at about the bottom of the thoracic spine, usually around L1, right below the thoracic spine.
Yeah.
So the lumbar spine, there's no more spinal cord. It's just the little nerves coming down there.
Yeah.
So when we image the whole spine, when we image top to bottom for MS, brain, cervical spine, thoracic spine. We don't need to do the lumbar spine though.
Okay.
Any of those things in this, like this is an MS lesion, this same patient might need a brain MRI too.
Yeah.
So you have to do all disciplines, obviously. as
For
far
the
as-
brain and all the parts of the spine?
And then, let's say cancers, or,
Yeah,
when
yeah.
you're doing something, you're doing all disciplines of.
Yep,
That's
yep.
amazing.
So, MS is a common reason to get MRIs of the brain or the spine, but not the only reason. And, probably the most common reason we do, if somebody comes in with a headache, or they have a syncope, they faint, or they have, a brain tumor, they get the same MRIs that an MS patient gets. We tweak it a little bit, so people do different sequences to see different things better, but it's the same anatomy, and I learned it all together. And sometimes, I don't know what a case is going to show. Somebody has a headache. It could be from an aneurysm. It could be from a mass. It could be from hydrocephalus. There's a lot of different reasons to have a headache, so you have to be ready to sort of see whatever you see.
Good job.
Well, we don't get them all, but we see a lot. I don't really have a whole lot more to show. I think that might be the last slide, but I'm happy to answer more questions.
So you hear about neuropathy, which I don't even know what that is, but it sounds very vague and general. Is that something you see on an MRI, or is that just, I don't know what it is?
I agree. I don't know what neuropathy is exactly either. And maybe some of the clinical people can tell us a little bit more about neuropathy. Neuropathy, in my understanding, is an abnormal sensation attributed to the nerves. And that can be kind of a paresthesia, like a numbness or a tingling sensation, but it could also be a pain or a burning sensation. Maybe you guys can make it more clear to me, because I don't really know.
Dr. Anzalone tends to get annoyed when people call it neuropathy, because neuropathy is of the peripheral nerves. Of the central nervous system, it's neuropathic pain. It's a different thing. So little bit, I'm not as familiar with it, but I've definitely seen her a few times go, no, you don't have neuropathy, you're having neuropathic pain. Which, you know.
But you're right, it's the clue is in the word, like neuro for nerves and pathology for, something going wrong. So I think you're right, something's gone wrong with the nerves, and a neuropathy is often pain or often
Symptoms like you were saying.
symptoms attributed to a nerve, and usually, like you said, sort of like a peripheral nerve, not something in the cord or brain, but one of the little nerves that's traveling out through your body.
Like, for instance, I have neuropathy. My father, who doesn't have MS, but has diabetes, has neuropathy.
Oh, because of numbness in the feet or
Correct.
something. Oh.
Yeah, so it doesn't have to be.
It's more of a symptom
Correct.
rather than like
Than this
the,
cause.
the cause
Yeah.
of
Right.
something else.
Correct,
Yeah.
absolutely.
Yeah, and I'll never make a diagnosis of neuropathy on an MRI. Neuropathy is something that's I might read it that's what they have. They have, lower extremity neuropathy. I never know what quite to do with that, but I just look at the I just look at the MRI and see, do they have a mass, or do they have a disc herniation or something like that. So it's a symptom, but not something that we see on an MRI.
But you can see it on some other instrument, right? We went once to a seminar, and they said I have neuropathy, and so we went to that institute, and they did some pictures, and then it shows my leg, and this is red, and so on. So this is your neuropathy. And
Well, they can measure the electrical conductivity through the nerves
Is
with
it that? Okay.
EMG or with
Yeah,
EEG, where they're sort of assessing the function of the nerve, not with pictures so much, but sensing the resistance and the through transmission of electrical signals.
I
So
didn't do anything
there are ways to
about
measure
it.
that, but
They wanted a lot of money, so I didn't do anything about it. I still have it, so.
yeah.
Question, I don't know if you know, but I'll just ask, do you know what is on the contrast and why it affects the, liver or kidney, those two?
Well, let's take one step back. So in the imaging world, the main kinds of cross-sectional imaging we do are CT and MRI. Now, a CT scan is based on X-rays. So you sit in a scanner, and it's similar to an MRI. You lay flat, and there's something that spins around you. What that thing spinning around you has is an X-ray emission source over here and a detector source on the other side of the ring. The X-rays shoot across towards the detector, and the patient is right in the middle. They shoot through the patient, and whatever X-rays get through, so let me start over. They shoot through the patient, and the whole thing spins around. So they shoot through the patient, and the detector detects how many X-rays are getting through the patient and how many are getting absorbed, and in what pattern. As it spins around, there are actually multiple sources and multiple detectors. As it spins around and the patient slides through, what you're able to do is to create a three-dimensional space of data. What the contrast is in a CT scanner is an iodine-based contrast. The iodine is useful because it's a very high atomic number, and high atomic numbers have big nuclei, and because they have big nuclei, they interfere with the X-rays going through the body more. So they absorb more X-ray beams, and they show up in a characteristic way. Just like your bones look brighter on an X-ray because more X-rays get stopped by your bone than by your flesh, by the air in your lungs, or by the fat in your subcutaneous tissues. The bones are denser. Iodine is similarly dense. So the contrast that we inject in a CT scanner goes into the veins, goes wherever blood goes, and it'll light up like bright on a CT scan. That kind of contrast, the iodine-based contrast, is more problematic and causes more people trouble than an MRI contrast, which I'll talk about in 1 second. So iodine-based contrast you should not get iodine-based contrast if your if your renal function, if your kidney function is bad. So people who have chronic renal problems, they're the ones who can't get iodine-based contrast. Iodine-based contrasts also are much more likely to cause an allergic reaction, where somebody has their body sort of attacks it, than the MRI contrast. So CT contrast is iodine based. The problems with it are allergic reactions and problems with the kidneys. MRI contrast is very different, and I don't think I can adequately explain how it works. Partly I can't barely remember it. I had to take a bunch of physics classes when I was in training to learn how to do it. MRI is not based on X-rays. MRI is based on magnetic fields. I'm going to attempt to explain this in a coherent way here. An MRI there's a static magnetic field, a very strong magnetic field, much stronger than the magnetic field of Earth where you are at any given point. That very strong magnetic field takes all the free protons in your body. Every single cell in your body has millions and millions and millions of protons. When you put them in a static electromagnetic field, all those protons are spinning, right? Now I'm getting into the weeds. But the protons are spinning in random directions, 360 degrees, every direction of a sphere. When you go into an MR scanner, all the protons stand up. They all are forced to go in the same direction by the strong magnetic field. When we run an MR sequence, when we run an MRI machine and take pictures, what we're doing is sending in electromagnetic pulses that disturb the protons going this way and let them relax back to their natural state. We turn them on and align them and then let them relax. When they relax, they go from a higher energy state where they're like sort of forced to be this way down to their more natural state. That relaxation gives off energy, and that energy is what we measure to see what's happening in the MRI. Very confusing, I know.
Oh, that's amazing.
That's
But-
a really good description.
Yeah, that's really interesting.
But so the contrast that we give is the contrast is a specific kind of thing. It's called gadolinium. It's a very high. If you look at the periodic table, gadolinium is one of the elements that's way down there. It's one of those you never heard about it in high school chemistry, but it's a very big atomic number. And the thing about gadolinium is it has a magnetic dipole. Now I'm getting to the edges of what I remember, but the magnetic dipole allows the excitatory pulses of MRI to show a bright signal. It basically lets it detect where that thing is. It's not shooting X-rays through it and finding a dense molecule. It's basically a molecule that's own magnetic field is interacting with the magnetic field of the magnet to give off a little energy and a bright signal. So whereas most of the body is just being affected by the magnet and by the pulses that we're sending through, this gadolinium contrast shows up on its own, if that makes sense. So MRI contrast is, first of all, we use extremely small amounts of it. It's also extremely inert, so it doesn't cause, very, very, very few people have allergic reactions to gadolinium. Iodine, not the case. You can definitely have allergic reactions to iodine. Very few people have allergic reactions, and if they have them, they're mild. Anaphylactic reactions to gadolinium is virtually unheard of. I'm sure it's happened, but it's very safe. And the MRI also doesn't cause problems with your kidneys. Gadolinium doesn't cause problems with your kidneys. It's filtered through your liver, but it doesn't injure your liver. So the short story is, I would not worry about getting MRI contrast.
I was
kind of
worried because I get MRIs every 6 months, and so it's like.
Yeah. And it is,
pretty bad.
you always think that you don't want to have things that you don't need to have. I get it. But I wouldn't worry about an MRI contrast. The number of times I've seen it cause any problems are vanishingly small. Iodine contrast for CT is a much more real concern to me and to patients. It should be too.
Well, I really appreciate you explaining that to me. I learned a lot.
Well, you got it. I don't know if my
No,
MRI.
I did. I understood.
If you guys if whoever's watching this on YouTube later could be like, I'm Googling this guy. You made a lot of that up. I'm pretty sure that's totally Fair.
If you had a reaction to iodine though, would you as a patient, that this is my situation, would the patient then say, could I please use a MRI instead? Is that the option that they have?
A lot of times, there's a lot of overlap for what CT and MRI can be useful to look at. But some things are much better seen by CT and some things are much better seen by MRI. So if you want to see something in the bones, if you want to see a fracture or you want to see a bones, that's a CT. That's a CT
Okay.
department. MRI can do okay at that, but not that great.
Soft tissue.
Similarly, if I was trying to read somebody's brain, look and see if their brain has MS in it, and I was only given a CT scan, I could potentially see some of the lesions, but with much less sensitivity and much less precision. So MRI is much better for seeing spatial resolution. It can tell the difference between things that are this far apart much better than MRI. MRI is much better at telling, are these two things the same kind of tissue or not? MRI is much better at contrast resolution or spatial or tissue resolution. So there's a significant overlap, but definitely things, if you're looking at the brain, an MRI is generally better, or spinal cord, MRI is better. Bones, blood, those are things that go
Those reactions to iodine, you just have to suck it up.
You can get pre-medicated, you can get some steroids,
okay.
like prednisone a little bit ahead of time, or Benadryl, for sure.
Reaction, have fun with that.
Yeah, we have pre-medication regimens, so people come in
So
the
they
night,
know,
you know, you
okay.
have a little prednisone the night before, then morning of, and a little Benadryl right before your scan, and most people are fine with that, but
Yeah, okay.
it can be serious too. Like if you have an anaphylactic reaction, you probably shouldn't get a CT contrast. And if you need to, sort of like an emergency, you should do it someplace where they can intubate you if they need to. But that's only for severe cases anyway.
Thank you. Thank you, Dr. Steele.
Thank
We
you.
appreciate
Thank you.
it.
Yeah, no problem. I hope I answered your questions, and thanks for having lots of questions too, because I didn't have a lot to sort of write down ahead of time.
It's kind of fun how it just flows, you know?
Yeah,
Yeah.
it's easier when I'm hopefully addressing specific questions and sort of opening the door for you guys to get your questions answered, your concerns addressed.
Thank you.
Thank you.
Yeah, that was super interesting.
Well, good. I'm glad you liked it.
Yeah, thank you
Hopefully,
for donating your Thursday.